Okay, so wrap this up with some modern approaches to the treatment of shock. And some of this may be very new to you. It's quite interesting. But we've had our discussion of hemodynamics, and they must be evaluated in conjunction with oxygenation variables. And in basic patho, I know you learned how to analyze arterial blood gases and do a little bit with oxygen calculations. But let's recap. Oxygen delivery is called DO2. And oxygen delivery, as you know, from basic patho, is divided into three critical factors. One is, what is your hemoglobin level? Because each one little molecule of hemoglobin can carry 4 molecules of oxygen. So hemoglobin is our oxygen carrying guy. So if someone is anemic and their hemoglobin level is low, they could be perfectly saturated. They could be 100% saturated, but if you've only got half hemoglobin saturated, your oxygen content in your blood is only half of what it should be, even though you look like you're fully saturated. So hemoglobin is a major component, and then you obviously have to have cardiac output to pump it around to all your tissues, and then, of course, saturation. Is it fully saturated, or is saturation impaired because of pulmonary dysfunction, ventilation, perfusion, mismatching, etc.? So, again, hemoglobin is a major, major player here. And my example here is if it decreases from a norm of 15, if it goes down by 1/3, down to 10, that the oxygen availability dissolved in the blood, the oxygen content in the blood, is reduced by 1/3. I don't care what you say. If your hemoglobin's down by 1/3, the oxygen content dissolved in your blood is down by 1/3. Even if cardiac output's fine, saturation's fine, you've got to have the hemoglobin to carry the oxygen. So when I'm teaching basic students, and their O2 sats are part of every normal vital sign, and they just go, oh, everything's fine. I said, what's the hemoglobin? Have you looked at it? Because you cannot put a smile on your face that all is happy in la-la land until you know that they've also got at least a reasonable hemoglobin. So when the crit, which is normally like 45, if it goes, reaches about 30, any further increases in hematocrit really won't affect the delivery. So this is kind of like your the low point, but if you get below that, you would want to optimize hemoglobin and hematocrit levels by blood transfusion. So arterial blood gases are great in looking at acid base. They're great at a variety of things. You can indirectly determine cardiac outputs by them, etc. But literally, it's totally ineffective in evaluating what's going on at the cellular level. We have no way of knowing what's going on. Well, we do, but not by looking at an arterial blood gas. So the VO2, now DO2 is oxygen delivery. The VO2 stands for oxygen consumption. How much oxygen is being consumed by our billions of cells. And interestingly, it's decreased in shock states. Why is that? Well, it's because there's decreased blood flow, but more than that, there's maldistribution of flow and impaired oxygen extraction. Even though it's getting there, there's impaired extraction by the cells. So these three things act together to actually decrease oxygen consumption in a shock state. So let's look at oxygen consumption, pardon me. And you can do this big old fancy schmancy equation, but why bother? Because we'll just look at what are the norms. And the average range of oxygen consumption is around 250 mils a minute with this range. But does oxygen consumption equal oxygen demand? And the answer is no, because the demand is determined by what the tissues need, what is their metabolic need. But the consumption is only what it did get. And remember, there's maldistribution of flow, there's impaired utilization of oxygen that's even there. So it's not really telling you. It's telling you what was consumed, but not the real true tissue need. So what can we look at? Well, if you had a central line in place, you could look at the saturation of venous oxygen. So in a blood gas, you're used to arterial blood gas, you're looking at the arterial sample. It's gone back to the heart, it's gone to the lungs, it's picked up oxygen, and so now you have an arterial sample that is oxygenated. So that gives you one piece of information. Your PO2 is whatever it is, and it's saturated at whatever. But that oxygenated or that arterial blood is now going to flow to all your billions of cells, and the cells are going to take what oxygen they want, so that by the time it comes back to the right side of the heart in the venous system, it is desaturated. So if you look at what came out at the arterial end and what came back at the venous end, you can get a better idea of what the cells are doing. So it's a global measure. The SpO2 is a global measure of oxygen returning back to the heart from all the tissues. And it's useful as an indicator of supply-demand of oxygen as long as the body's basically pretty normal and your vasoregulatory mechanisms are intact. So again, if an SpO2 is helpful in some ways, but it might not tell you that you've got some tissue and cellular hypoxia going on in some areas of the body because of maldistribution of blood flow in sepsis and in shock, or impaired extraction by the stuff. They want it, but they have impaired extraction and ability to use it. So at any rate, most clinicians would agree to aggressively optimize oxygen delivery if the SpO2 fell below 40. That's really, really abnormally desaturated. It goes out at 95 to 100%. It normally comes back near 80%, 75, 80%. So the goal would be, as a treatment endpoint, to get it at least 60 to 75%. And the SpO2 will only change and show improvement when the delivery of oxygen or the consumption of oxygen is no longer delivery dependent. Now, other things that we can look at besides looking at the SpO2 is we can look at serum lactate levels. And a normal serum lactate is less than 2 millimoles. And lactate levels greater than 2 are telling us that we've got some tissue hypoxia and anaerobic metabolism, and therefore lactic acid production. Lactate levels correlate with mortality. So the higher the lactate level, the increase in morbidity and mortality. And roughly an increase in lactate from 2 to 8, look at this, astounding statistics. It's associated with an increase in mortality from 10 up to 90%. And interestingly, hypovolemic and cardiogenic shock tend to have higher levels of lactate even than septic shock. Now, if you're going to ask me why, I don't know. It's just the literature tends to say this. Another thing we can look at when you're looking at your blood gas is base excess or deficit. And normal is -2 to +2. And if it's more minus than -2, you're acidotic. If you're more plus than +2, you're alkalotic. Well, looking at the base excess or deficit, if you will, value, this serves as a really quick indicator of the degree of inadequate perfusion. And if your base excess deficit is a value of -5 or more than that, like -6, 7, 10, this indicates inadequate perfusion and indicates that there is some anaerobic metabolism going on and formation of lactic acid. Some places are looking at mucosal, intramucosal pH in the stomach with use of specialized NG tubes, and they feel that this may be one of the best indicators of tissue oxygen balances. The gut mucosa uses 90% of the oxygen it gets. Its normal pH range is here, as you see, 7.35 to 7.41. And if it's less than 7.32, it's more acidotic, it's telling you that there's an oxygen deficit. And this seems to be a really early sign, and the gut pH actually changes many hours, a day even before that we would see a change in the base deficit. So some places are using this. But again, in shock, what we see in the irreversible stage is it leads to death. And again, the common theme to any form of shock is hypoxia at the cellular level. So what are some of the treatments? Well, certainly we want to treat the underlying disease. If it's hypovolemia, fill them. If it's MI, support the heart. If it's sepsis, the antibiotics, et cetera, et cetera, et cetera. We always want to follow our ABCs of care, airway, breathe, circulate, which now is BAC, breathe, airway, circulate. Pharmacological therapies, many. Vasopressor support, adrenal support, corticosteroids, et cetera, to reduce mortality. We want to attempt to monitor and stabilize the vital signs. And one method that we can use cardiac assist devices, such as the intra-aortic balloon pump, ventricular assist devices, pacemakers, etc. So let's just end with talking about one of these devices, the intra-aortic balloon pump, IABP. And this has been around for, Lord, since around 1960, at least. And I love it in its simplicity. It is, in fact, a catheter that is inserted retro, right, up usually they do a femoral approach, and they put it into the aorta, into the thoracic aorta, and it's hooked out here to a big machine. But the balloon pump itself is a catheter with, as you see, a big sausage-shaped balloon. And this balloon is inflated with anywhere from 30 to 60 mils of the gas. And if you think of a normal stroke volume with each heartbeat being an average of around 70 mils, if this is a 30 to 60 mil thing, you're half to almost an entire stroke volume concept that you're talking about. Now, in order to understand the intra-aortic balloon pump, you need to understand or know one word, and that one word is counterpulsation. That means that when the heart is active in systole, the balloon is inactive or deflated. When the heart is inactive or resting in diastole, the balloon is activated or inflated. And to look at that, what happens again? Here we have an inflated balloon, a deflated balloon. Well, let's first talk about diastole. When the heart is at rest, the balloon is activated, counterpulsation. It is inflated. What does inflation of a balloon in your aorta, your thoracic aorta, do? Well, if it displaces the blood that was in the aorta. So it displaces blood upward this way. So it goes up the aorta. And what do we know about what goes on in the aorta during diastole? Is that's the takeoff route for our coronary arteries. And our coronary arteries are perfused mostly during diastole, when the heart's at rest, because when it's in systole, the muscle is literally constricting what can flow through that muscle mass. So in diastole, if you move forward, move blood backwards up the aorta, you increase aortic diastolic pressure and you improve coronary artery filling and nourishment. So you feed the heart. It also displaces somewhat downstream, feeding the kidneys as well. Okay, so that's what it does during diastole. Feed the heart. Now, during systole, when the heart wants to eject its contents out the aorta, obviously you can't have an occlusive balloon in place. Blood can't go anywhere. So you have to deflate the balloon. So what does deflation of the balloon do? You now have a void of 30 to 60 mils of space occupying whatever you have in there, so that now you literally decrease afterload by that much. So you allow the heart to pump more effectively. It is not having to pump against so much resistance. You have decreased afterload. So that's why this intra-aortic balloon pump is wonderful. It improves coronary artery filling, you feed it better, and then when it wants to contract, it doesn't have to do so much work. So it is a cardiac assist device. And again, the key word to remember is counter pulsation. So we completed our discussion of shock, and remember to look at your case studies and go to your forums and discussion with your colleagues. Thank you very much.